So this is a very special talk that I'm about to start. Actually, this morning I was thinking, how many people can I expect for a story about GSD type 0B? I was not expecting so many, to be honest, because it's even within the audience of this weekend, an ultra rare disease. I have nothing to disclose for this presentation. Only I have to acknowledge several people with whom I've been collaborating in the last few months. Well, as a short introduction about myself, for those who do not know me and for those who are curious about the strange accent, my name is Derks. I'm a metabolic pediatrician coming from Groningen in the Netherlands, and I'm very thankful for AGSD for having me and giving me the opportunity to present on several topics. It's my third time at AGSD. First time was in 2017 in Chicago, which I really enjoyed. Then the second time was virtually during the pandemic, and I'm happy to be back. So also the fact that I can share this story makes me happy in a certain way, but also it is, well, it's strange in a way because of the origin of the disease. But it's nice to be able to put also very rare GSD subtypes in the spotlight. At the end of my presentation, I hope that you've learned from this very special boy that presented in our hospital in December last year, in whom we diagnosed GSD0B. It's a muscle GSD subtype that can only be diagnosed by DNA testing and by investigations in muscle. There's not a good biomarker in blood or in urine, so it's very hard for doctors to diagnose this subtype. Can be very severe disorders, and that's why doctors should consider the disorder under these circumstances, and some of them are not very specific. Is there anybody in the audience with experience with this subtype? Yeah, with experience with GSD0B, people who have the disorder, or no? Okay, you have one. Yeah. Yeah. Well, before January, I had no experience. So, but when you're confronted with a patient, you have no choice, yeah? And that's what this story is about as well. There are no guidelines, of course. So I'm remembering your story from yesterday, but this is really no area for guidelines yet, but probably not in the first 5 years either. Sorry? They're writing the story. Yeah. And also recommended treatments are still non-existing, but in the presentation I hope I will be able to show you some examples of treatment options and related questions that we had along the way. And the case definitely shows the value of collaboration not only within a multidisciplinary team, but also with a pharmaceutical company. So let's go. On the 19th of December, last year, everything suddenly changed for this family. It's the second boy in the family. Parents were healthy, unrelated, of Caucasian origin. And you see some history in the medical, or the medical history of the boy. And he experienced syncope at school at the age of 5.5 years. And at that time, there was evaluation by a pediatric neurologist and a cardiologist, but yeah, actually everything turned out normal. So electrocardiogram, electroencephalogram were all normal, and there was no diagnosis made. And life moved on until he was almost 9 years of age. And during the evening, he was having kickboxing practices. And then suddenly he presented out of hospital cardiac arrest. The boy was resuscitated by his father. And basic life support was immediately started by him, and they connected the AED, and there was a shockable rhythm, and he was recovered, and after a few minutes there was signal again. The ambulance came in and they brought him to our pediatric intensive care unit. What I found very interesting, at the emergency ward in our hospital, his blood lactate was only 3.2 millimolars per liter. And normally if children are resuscitated, lactates are sky high. Looking backwards, I interpret it differently as doctors were interpreting at that time. So he was at the intensive care for quite a long time, and some pieces of the puzzle appeared in the next days. he tested positive for COVID, and also the parents told that he had eaten little that day, so perhaps there was a fasting component in place as well. He recovered from an aspiration pneumonia. He could be decannulated, and he recovered pretty well. So they could transfer him to the pediatric cardiology ward, and they started a beta blocker at this dose. So we had some considerations about glucose metabolism with regard to the beta blocker as well. And I just indicated also his height and his weight because I think it's of interest. And perhaps we can discuss about that a little bit more detail in the interaction that we have later. The cardiologist considered an ICD, but he was considered too short, too young, but also the risk of inappropriate shocks was taken into account, so they referred from that. And then at the end of January, the results came from exome sequencing, and that surprised many. So then the diagnosis was made, just one variance was found, and the diagnosis was there. And then we had to start thinking about how to solve that. Because, of course, this family was 1.5 months in the hospital. They were really traumatized about everything that had happened. And then, well, sometimes we say with a diagnosis, you get a prognosis, but it's not entirely clear in this case. So here I can acknowledge you, Will. Very nice graph that we made recently. It shows where the defect is in this glycogen synthase deficiency, which is solely in the muscle, in the skeletal muscle and in the heart. And I also like the graph in the right because it nicely illustrates the phenotype, the organ phenotypes of the different glycogen storage diseases. And from that cartoon, you can nicely see that GSD type 0B is really hitting the skeletal muscle and the heart. And it's also important to emphasize that 0 alpha, GSD 0 alpha, on the left top is only a liver genotype. So it's really a different disease, 0 and 0. Well, in that time, of course, if you're confronted with a patient like that, and the parents immediately asked, what is known in the literature? Are there guidelines? These are the typical parents that ask that, fortunately. And there were only 3 or a handful of papers that I will show you shortly. But in particular, I would like to acknowledge the first paper about GSD0B. It's from a Swedish group who at that time published about 3 siblings, of whom 1 acutely died, and they followed up the 2 children for a while. And I thought, I'm really interested to know what had happened next, because this was in 2007. So we're so many years further now. What has happened with these children? What has been there? It's not exactly the natural course because doctors tend to interfere, but well, I wanted to know what the effect was of treatment, and in particular the beta blocking and or ICDs, and perhaps they even tried something with diets. So I emailed them, but yeah, that's what's happening. The last author already had passed away, and so I really had to find my way to find these colleagues, and I will come back to that, how that went. So this is a table that we, well, could pull together with the pediatric patients presented in literature up to then, 3 with sudden cardiac deaths, and 2 patients with in whom the diagnosis was established post-mortem. And yeah, there was also a patient from Japan with certain cardiac death despite early diagnosis, despite dietary management, because that child also received uncooked cornstarch 4 times a day, 2 grams per kilogram, to maintain blood glucose levels, whatever that may mean, because the authors are not very specific on that topic. So we had more questions than answers at that time, and from that starting point, we had to make decisions. So we didn't really know about the prognosis. We did not really know how to measure and or to improve cardiac energy metabolism. Is it reasonable to try to give alternative energy substrates instead of carbohydrates, or perhaps only fast carbohydrates. What's the role of catabolism at all? So is there a liver phenotype? Perhaps not because of the genetic defect or the enzymatic defect in the liver, but can we manipulate that? Um, and all these questions and potential interventions, one would like to balance in a rational way, but also in a sensible way with the burden of this family, and in particular this boy. So these were some of the energetic options that we considered at that time, alternative substrates like creatine, carbohydrates, but also fat-derived energy sources, such as the ketogenic diet, modified Atkins, MCT, so medium chain length triglycerides. We considered DL-beta hydroxybutyrate because we have experience with that with patients with another muscle phenotype disorder. And we considered even delta G. Perhaps some of you have known of that ketone ester, which has really an awful taste, but is very efficient in achieving ketosis in a very fast manner. And we considered triheptanoin UX007. I don't think it has anything to do with James Bond. And the brand name is now Dojolvi. So I was in a doubt. And one thing to do when you're in a doubt is share your doubt. So we posted the question on MetabL, which is a chat box for metabolic freaks. There were not that many answers that came back. So that taught me that, well, either people are working on that and not disclosing that at the moment, or there's not a lot of experience. It can also be both. But I simply couldn't believe that there weren't more patients out there. Also because the family, simultaneously through social media, got in contact with some families in the United States and some other areas. So I knew that there was more out there. So we just persisted with that. And in parallel, we reached out to Ultragenics after also multidisciplinary meetings in our center. What would be the best dietary regimen to aim for? And we thought that triheptanine at that time could be a good option for several reasons. So to go a little bit more in detail on triheptanoin, and for those who like the biochemistry, so the core of the triheptanoin molecule is a glycerol, so it's 3 carbon molecules, and they're esterified, and these are fatty acids. But they are not even sized, so it's not C8, C10, or C6, but it is odd chain. And the odd chain allows not only to produce energy out of fatty acid oxidation, but also to fuel to propionyl-CoA, succinyl-CoA, and then the TCA cycle. So it's another way to generate energy. And there is even a theoretical third option, just as Enrico was also telling glycerol, it's also a substrate for gluconeogenesis itself. So in theory, it's very elegant if it works. But the question, of course, was, could it work and how can we measure that? But we didn't have time to find that out. That is finding out in an explorative way by simply doing that and discussing with the parents what are the pros and the cons of that option. So this is a very brief timeline of the last months. And I would appreciate if you don't take pictures if I have that sign on there. But if you want more information, I'm very open to say whatever I know. I don't want to keep anything behind. But under these circumstances, there also is a confidentiality agreement that I had to sign with the companies. And that's the only way by which I could provide this treatment to my patients. So I would be like to be very sensitive with that part as well. So on the same day that the diagnosis came, we posted at MetabL, and some questions came in and input from colleagues who said, well, I should start ketogenic diets, I would start the modified Atkins, but in the end, we thought it's better to start with triheptanoin, and it was rewarded extremely quickly. They were so helpful with doing that, and I really appreciated that a lot. But then in parallel with all the bureaucracy with ultragenics, there is also part of bureaucracy with regulatory agencies in the Netherlands that we had to do in parallel. I had to convince my colleagues, of course, there needs to be parental consent also from the guidelines that we have as a professional organization. And we started with a few baseline assessments also to measure the basic metabolic rate because the dosing is based on the daily caloric intake, but that depends on requirements. And the impact of this treatment is rather big. So then it is nice to assess the requirement as closely as carefully as possible. So we did with indirect calorimetry, and we and that taught us that his energy requirements are actually underestimated if we would use the normal formulations the dietitians use. So we wrote a protocol for exploratory measuring efficacy and safety, and we started doing this on the 19th of February, within 3 weeks after diagnosing him. And well, after a hospital admission of more than 3 months, he was discharged from the hospital. After the first Meetup L post, we were invited at the Scandinavian GSD meeting. And being able to meet Scandinavian colleagues, it made sense to ask them, do you know the authors of the first paper? And by that, we came in contact, luckily. And that was really nice. They were very friendly, and we were able to add our case to the additional cases that they had been collected at the time. So currently there is, well, yet unpublished, but it will be submitted very shortly, information about 15 cases, and it is widening the phenotypical, but also the genetic description of this disorder. And that's very helpful to try to understand when to do the diagnostics, and perhaps in the future also what treatments may be more rational. So we started monitoring with our patients, and we applied techniques that we have for the normal trials. So we assessed for adverse events. It was not very easy for the boy to take triheptanone, in particular the larger volumes, but the family really did great. It was reasonably well tolerated, as you can see on this slide. We also checked for biomarkers in plasma, not necessarily because we believe that there is a biomarker in plasma available to diagnose the disorder, but biomarkers are also important to see that triheptanone is reaching the mitochondrion, for instance, that it is doing what we think it does. And we also checked, for instance, for triglycerides to see that we are not creating a hyperlipidemic profile, for instance. We are checking urine, but I have no information on that. But what is very interesting, we also regularly did echocardiography and electrocardiography. And in these early phases, but I realized that it is very subtle, and I'm certainly not a pediatric cardiologist, so that's the disclaimer with this story. But our pediatric cardiologist has the idea that in these precordial leads, in particular this area, so after these large peaks, which are called QRS, it is really abnormal, this repolarization. And only in the last 2 ECGs, we see that that is changing. So it is much more stable, it is less of a chaos, and it's only 2. So we are still very careful with these abnormalities, but they were not longer seen. And at this point, of course, we do not exactly know what caused these changes and what role triheptanone played. But from other ketone body treatments, it is known that although ketosis can be achieved really within hours, it can take days to weeks before clinical improvements occur with a certain ketosis-oriented treatment. So that is really a reason for us to maintain on this path as long as it is tolerated well. Yeah, we also looked at the patients or the parents reported outcomes. Perhaps there is minimal improvement. And the boy actually will come back next Thursday again when the doctor will be heavily jet lagged. And so we will see then how the next follow-up will be. So to conclude, GSD type 0B, it's an ultra-rare glycogen storage diseases. We cannot diagnose the disorder at this moment in plasma or in urine, so there should be a level of suspicion, but that is for relatively aspecific symptoms. But perhaps the combination will make doctors think of it, like the family history of sudden cardiac death, syncope, arrhythmias, cardiomyopathy. I think exercise intolerance or myopathy is very difficult, in particular in young children, to objectify. But the flat lactate curve was observed during some of the patients that the colleagues from Sweden collected. And I think looking backwards, the lactate of 3.2 after resuscitation might be indicative too. CK remains normal, and in contrast to, for instance, McArdle's disease. But this combination may mean that those interventions on exercise support that are considered to be helpful for McArdle's could also be applied for this boy. So actually, on Thursday, I'm proposing to the parents, could we perhaps do such a semi-ischemic forearm test to objectify that or to substantiate that a little bit further. And we're still questioning, is this the right treatment? Yeah, of course, the question behind the question is how fast can this triheptanoate efficacy be? With other ketones, I know it can take months. So perhaps it is true what we see at the electrocardiogram, and we will just follow that up. And in the meanwhile, we are wondering, can we help him a little bit more with a dedicated and well thought exercise program? So I'm at the end of my presentation now. I would like to acknowledge my colleagues at UMCG with whom we treat and monitor the patients. Fouki de Boer is very important in this story. She's our metabolic dietitian taking care of our GSD patients. Andrea, she's at the meeting here as well, working as a metabolic pediatrician too in our center, our cardiologist, but also the hospital pharmacist, because this is the colleague that needs to support me with all the regulatory stuff and with the connection with Ultragenics. He is very important. And our clinical chemist is also very helpful with the monitoring and also with searching for perhaps biomarkers that we are not aware of yet. And also I would like to acknowledge the fact that Ultragenics was so supportive. And on the right hand, you see all the authors for the paper that is hopefully submitted soon. And in particular, Sarah and Gitan, who are the first and the last author of this project. They did a great job in collecting all these patient stories, and hopefully there will be a next step to more knowledge about this ultra-rare glycogen storage diseases. And I thank you for your attention.
Just a general question.
Yeah.
Since we're going to go into patient-reported outcomes next, you showed no change or maybe a minimal change. I guess my question was, did he have any symptoms or anything that you would have expected to see a change in his day-to-day living, where you would have maybe seen a change there?
Yep. On the longer term, I hope muscle strength and perhaps also exercise intolerance, being more energetic or having more stamina. And I realized that that can take longer than the time span in which we are currently measuring. So that's one of the things that I'm considering. But I think it is anyway very much biased by everything that the family has went through. So they are really extremely scared of sending him to school. Because if you read the reports, all these children, they pass out at school for whatever reason.
They spend so much time there, right? Like, statistically, it's probably the place it happens.
Yeah, that could be. But you have this enzyme deficiency from birth. It could also be that we simply do not diagnose those children that acutely die. Yeah.
Hi. So in my knowledge, no lab anywhere is doing enzyme testing for GSD0 clinically, or I don't know about research basis.
Yeah.
And then for the diagnosis, is this gene on cardiomyopathy panel now? Let's say if somebody sends a cardiomyopathy panel,
Yeah.
and is this gene often included in cardiomyopathy panel or not? Or you need a whole exome sequencing in order to for this gene to be picked
Yeah.
up as a one of the culprit for the cardiac disease.
Yeah.
So there is like for diagnostic purposes, I'm
Mm.
thinking like what are the ways to diagnose that?
Well, you raise a very important point, and this was actually the reason why our genetics lab has changed this and included this gene for both panels, so for arrhythmias and for cardiomyopathy, just to be sure that we are not missing them. Probably we would also need them in the metabolic autopsy or in the genetic autopsy panel, because we cannot exclude that we are missing patients that pass out during infections that are considered sudden infant death, for instance, but that appear to have this as an underlying defect.
How many are missed? That's what
Yeah,
my concern is. How
yeah.
many are missed?
But we share that thought. And this is one of the ways to figure that out, to be sensitive of adapting these panels with this gene.
Exactly.
Yeah.
That's what I think there
Yeah.
should be it should be an effort
Yeah.
that
I
everybody
agree.
should made a way to add this gene in the panel.
Yeah.
The reason I'm asking is very early on when the cardiomyopathy panels, all these panels is a new thing, it's not very, very old.
Mm.
So it came up and lot of some of the Pompe patients were missed because that panel did not have GAA in it.
Yeah.
So then when we started looking at what genes are in the panel, GA was not in panel.
Yeah.
So at that point we started making little like knowledge base and think that if you're doing cardiomyopathy panel, this has to be part of it. And now most of the cardiomyopathy panels do have GA.
Yeah.
So is it time to include this in cardiomyopathy?
Yeah, that's one important step. But I also would be in favor if you have a patient that would hit 2 or 3 of these boxes, but your panel turns out negative, I would proceed with a muscle biopsy. So in our practice, the threshold to perform liver and muscle biopsies has increased because of all the improvements in genetics, and that makes sense. But under these circumstances, I would probably lower that threshold again and do a muscle biopsy if the panel was negative.
But muscle, there is no enzymology available for muscle biopsy.
No, but you could do the stainings.
Yeah, that's all you can do.
Yeah.
Histology, you can just
Yeah.
do histology.
And on the research basis, I don't recall by heart, but one of the groups did enzymology also in fibroblasts. So
It would be good to know.
yeah, yeah,
And on fibroblast?
yeah. I think it is in fibroblasts even. In one of these studies, it is
So
mentioned.
the deficiency can
Yeah.
be picked up on skin fibroblasts.
Yeah.
So this is muscle specific.
Yeah, yeah.
Gene deficiency.
So one of these groups did studies in fibroblasts. Yeah. But in our situation, I would probably reach out. So in the Netherlands, generally there is a tradition to do enzymology. We still have enzymology also in place for the disorders that are picked up by newborn screening. And either the group in Amsterdam in our country or in Rotterdam, who has a focus on the liver glycogen storage diseases, we would reach out to in the first place. If the groups who have published cannot guide us.
Oh, I would love to know the name of that group because I get calls oftentimes
Mm.
that do you know of any lab anywhere doing GSD0 enzyme testing?
Yeah.
I'm not aware of it.
If you send me the email, I will send you the report back.
Okay, one question.
Yeah.
Along with the C7, what dietary intervention did your patient have?
Well, what we did, we increased his total caloric intake. So he's really having to eat a lot now, but we also see that at his body weight, because his BMI is getting more much towards normal, but in particular more calories, and then still around 35% of these calories it's triamcinolone, and that yeah.
Any manipulation with the protein in the carb?
No, no, just normal daily requirements.
I did just check the metabolic map of panel at GDX, and the GYS1 gene is on there.
Oh, okay.
Interesting. Maybe more.
But it's often a local policy, of course, which genes are included in which panels. Yeah,
I just know a lot of people in the U.S. order from there. So
okay.
it's interesting.
Yeah. Yeah. Yes, that's correct.
One thing that I was going to think that for us, if there was a sudden cardiac event and the lactates were on the lower end, I think there's less of a tendency to think of metabolics. I know in our institution we get called for persistent lactate elevations that are
Yeah.
unexpected. So this is an interesting thing because I'm wondering if we would get a call in this instance,
No.
knowing that that wouldn't have been a typical tip-off. So this is that makes me wonder if we would have even been considered as a consultant in this case.
Probably not. We weren't at that phase either.
Yeah.
But looking backwards, it was.
I know that's
Yeah.
interesting.
Yeah.
And then also, was this child, I'm just curious, an exercise avoider? Like, is he athletic?
Yeah.
Or was
No,
he more avoidant?
he was an avoider, and very different from his older brother.
Yeah, that's what I was expecting.
Yeah.
Test older brother?
Yeah. Luckily, yes. Yeah. Okay.
But I think like GSD 0 is underdiagnosed
Yeah.
disease.
I think so too.
GSD 0B is even more than that.
Yes.
Yeah.
GSD 0, like generally I'm thinking it is underdiagnosed. Like people have a hunch, but nobody
Yeah.
has picked up.
Yeah, well, that's why I wanted to tell this story, and that's also the reason why I prefer to tell it rather than making a poster, because there are so many small stories behind the story that are almost impossible to reflect on a poster.
So what was the oldest patient in your cohort?
Yeah, there were so.
Ours was diagnosed as an adult, and
Yeah.
he lived a very, he was a pretty athletic person.
The
He was a
Italians.
bicyclist and
Yeah, the Italians also wrote about adult patients without cardiac manifestations. But,
They're all young patients.
in these columns, you have the age of onset and
Yeah.
the parent's age.
Plummeter.
so that's I was 42.
Yeah. For time's sake, shall we move on with your presentation?